All right, so we have here two X-ray views of the right shoulder. The first is an anteroposterior AP view, and the second is an axial view. Now, when I look at this, the first thing I notice is that the humeral head isn't sitting in its usual position relative to the glenoid fossa. It's displaced posteriorly and impacted on the posterior margin of the glenoid. This immediately raises the suspicion of a posterior dislocation of the shoulder, which, though less common than anterior dislocations, can sometimes be missed. We can also see a large reverse Hill-Sachs lesion on the humeral head, which is an indentation fracture typically seen in posterior dislocations. The presence of sclerosis around the margin of this defect suggests that this is not an acute dislocation, but rather a chronic one. This fits with the history provided. 3 months of symptoms, which is consistent with a delayed presentation of posterior shoulder dislocation. Additionally, there's no sign of fractures elsewhere. The acromioclavicular joint appears normal, and the lung field, at least the part visible here, looks clear without any evidence of pneumothorax. So, in summary, what we're seeing here is a long-standing posterior dislocation of the shoulder, complicated by a large reverse Hill-Sachs defect. Given the chronicity of this injury, I would suggest that surgical management is likely required to reduce the joint and repair the defect. Now, an examiner might ask me, how would you assess for shoulder dislocation on plain film? Well, the key is to look for congruency between the humeral head and the glenoid fossa. In posterior dislocations, the humeral head may appear locked in a fixed posterior position relative to the glenoid. You may also see signs like the light bulb sign, where the humeral head appears rounded due to its internal rotation, or the rim sign, where there's widening of the joint space due to the posterior displacement. Another question that might come up is, why are posterior dislocations frequently missed? They are less common than anterior dislocations and can be subtle on plain films, especially in AP views. That's why alternative views, such as the axial or Y views, are critical for evaluating joint alignment properly. Lastly, they might ask about the management. In a case like this, where the dislocation is chronic and there's a large Hill-Sachs defect, surgical intervention is often necessary to restore function and prevent further damage to the joint.